We have this condition we all see in our clinic we call smoldering myeloma, which is people who clearly have cancer on their bone marrow, myeloma on their bone marrow, and yet we choose to watch and wait. There are some of those patients who will progress very quickly, we know from experience. Should those patients be treated, Dr. Lonial? High risk, well, first of all, how would you define high risk smoldering myeloma, briefly, and would you treat it?
So I think high-risk smoldering, in my view, using sort of an objective set of data, really follows the ECOG Mayo criteria that we use in the current ECOG trial, which is randomizing patients between observation and single-agent lenalidomide. And that looks at 3 criteria: greater than 10% plasma cells, M spike greater than 3, and a free light chain ratio greater than 8 or less than 0.125. And if you have all 3 of those, your risk of progression is very high. Median time is about 2.5 to 3 years. If you have only one of those, your median time to progression is greater than 10 years. So that's a good way to risk stratify patients. That's simple. It's all tests that we do regularly. It doesn't include complex imaging. I think the question about treating them is much more difficult. I think for patients that fit into the regular smoldering myeloma category, the standard of care remains observation, and it remains close observation.
Let me stop you with that. Does everybody agree with that? Would you treat a high-risk smoldering myeloma patient?
Yes, I mean, I think that's actually important to acknowledge. It's actually one of the most difficult diagnoses to make, quite frankly. So for an oncologist practicing, I think that we see, we focus on this a lot, but I think for a community oncologist who sees breast cancer and prostate cancer, it's rather clear-cut when to treat and when not to treat. So I would say we need to acknowledge that this is actually a very difficult decision, and we see referrals all the time about confirming this is smoldering or active myeloma. So I think that's important to acknowledge. And so as we get into these nuances that we talk about here, I think it becomes very challenging to apply this clinically, quite frankly. So when you get down to the high-risk smoldering, I think that, and again, it's also important to, the criteria have changed, right, in the last 6 years.
Speak that. What are some new criteria have come out which suggest it's not smoldering, you should just treat straight away, which are?
So I think that we've parsed that way.
Can you remind everybody what those are?
Yeah, absolutely. So we, I think, recategorized or identified a subset of patients with ultra-high-risk myeloma. And those are patients with a free light chain ratio greater than 100, a bone marrow plasmacytosis more than 60%, and then lytic lesions on MRI more than 1. And those are patients who have a very
PET scan, I guess.
Or on PET scan, who have a very high risk of progression in the first 18 to 24 months.
So those patients should be treated today, is that?
So that's what the new IMWG criteria suggest, yes. And so then we have the leftover smoldering, intermediate and high-risk patients. And so for those patients, I agree with Dr. Lonial that those patients, for now, should be observed unless they're on a clinical trial.
Anybody feel differently? Anybody feel we should be treating more aggressively early? We don't watch breast cancer for very long before we treat it.
Well, I think there are various strategies, Keith, but I agree completely with Jatin that the on-protocol approach makes the most sense until we can dissect the best answers from the various opportunities we have. Our own experience has been that the use of monoclonal antibodies experimentally in this setting has been quite favorable. But like everything, as you move into then combining an antibody with, say, immunomodulatory therapy, we've been struck that whilst the combination is very active, out of the box have come some interesting and challenging toxicities. So it kind of sharply defines that one has to be careful. And I think the immuno-oncologic space in smoldering is very attractive. But again, it gets to this question of toxicity benefit, and we have to be, I think, appropriately prospective in how we evaluate patients in that regard.
I would like to just point out that with the 3 new criteria, I think the lesions, that's clear. We just have better technology for picking up bone lesions. And the bone marrow, notwithstanding the heterogeneity and sampling issues of a bone marrow sample, 60% I would buy, but I think the free light chain ratio is a little bit different.
I was sitting here thinking that I still challenge somebody has a free light chain of 110 and they're perfectly well.
Right. I think and issues in that include things like what is lead time bias? How long has this patient already had a free light chain? So particularly for the community oncologist, if they've already had a free light chain ratio for over 100 for 2 years, do you need to start treating them just because we have a consensus statement saying that? And I think it's important to remember that we don't have phase 3 prospective studies showing that this particular population, because at the end of the day, it's all about risk and benefit. What is the benefit and what is the risk of the therapy you're implementing? And are you making a dent in that patient's overall survival and eventual natural history? Because the argument would be, if you follow these patients closely, you could even say, maybe we should randomize them to monthly follow-up and intervene.
But remember, the risk in these patients is renal failure. So it's not often, if you look at the Spanish trial, the randomized Lendex versus observation, which I think is not the answer.
Correct.
But many of the patients in the control arm presented with renal failure, and those patients were being watched relatively frequently.
And interestingly also, Sagar, many of them, in fact, the lead CRAB-defining event was actually bone disease.
Agreed, yeah.
And I think that the important message I've always found too is that, you know, again, if I have a smoldering patient with osteopenia, I'm very comfortable recommending appropriately, with the usual caveats, of bisphosphonate use. I'm particularly interested in that because I think actually beyond the simple effect on bone, there's this intriguing evidence that bisphosphonates may have a favorable impact on the gamma T cell population. So in fact, hypothetically, may have an immunological platform as well. So it's just interesting.
So let me summarize again. I think just want to make sure we wrap up for the watching physicians. The general sense is that we still don't treat smoldering myeloma. We may have a lower threshold for people with a high plasma cell cytosis, and certainly for people who have evidence of disease on bone. But for the most part, we still recommend watchful waiting in this population. So let's move on.